We started our Tavi program back in 2007, and at that time the manufacturer asked us to use echocardiography during all our cases because, as they explained, at the beginning we need all the help that we can get. Well, now we're many hundreds of Tavi cases later, and we still use echocardiography during every single Tavi case that we perform. In addition, it plays an absolutely vital role in terms of patient selection and follow-up. In this DVD, we're going to explain to you how you can use echocardiography as well for patient selection, peri-procedure monitoring and follow-up, and how it fits in and complements the other imaging modalities that are available to us. I hope you enjoy it. Echocardiography plays an absolutely pivotal role in the patient selection for Tavi. Of course, it's used initially to establish the diagnosis of severe aortic stenosis. And I have to admit, when I started performing echo many years ago, I used to think that the assessment of AS was relatively simple. All we had to do was record the velocities across the stenotic aortic valve using continuous wave Doppler, and then by application of the Bernoulli equation, we could calculate the peak and mean gradients. And you can see a classic example of this on this slide here, where we've traced around the envelope an apical continuous wave recording and calculated maximum pressure gradients of nearly 100 millimeters of mercury and a mean of over 60. So this is clearly a patient with severe aortic stenosis. However, very often the patients we're assessing for Tavi are much more complex, and consequently the assessment of aortic stenosis is also more complex. One of the situations that we frequently come across is illustrated in this slide here, where we have a patient with classical low flow, low gradient aortic stenosis. In this particular case, we can see that the low flow is caused by poor left ventricular function, which is going to result in a low stroke volume across the aortic valve. And that low stroke volume is going to lead to a reduced gradient and also a small valve area. So we will end up with a disparity between a low gradient, suggesting perhaps mild or moderate aortic stenosis, and a small valve area, which suggests severe aortic stenosis. And the question for us is, which is right? Now, in this particular situation, I would have a very low threshold for performing stress echocardiography, because whether you perform stress by exercise, if the patient's capable, or by dobutamine, all you need to do is to put up the stroke volume a little bit and see what happens to the valve area and valve gradient. And this is a very useful technique. Now, in this next slide, we can see a patient whom we were working up for assessment via stress echocardiography. And when you look at the baseline recordings here, you can see that the patient only has a very modest peak aortic valve gradient of 35 millimeters of mercury. And the patient is in atrial fibrillation. And as you can see, as we were taking the baseline recordings, the patient had a ventricular ectopic, a compensatory pause, and then post-ectopic gradient potentiation. So the gradient leapt after the compensatory pause and the increase in stroke volume. So when we could see this increase in gradient without an increase in aortic valve area, then we can be reasonably confident that we're dealing with significant aortic stenosis. And in this particular case, we decided not to proceed with the stress echo because we'd already got the answer here. So it's well worth assessing these patients if they have irregular RR intervals to see what happens to the valve area and the valve gradient on a beat-to-beat basis, because that can often give you the answer. Now here's another patient with a different form of low flow, low gradient aortic stenosis. It's referred to us from another hospital with a maximum pressure gradient of nearly 60 millimeters of mercury, but a valve area of less than 0.8. So a bit of a discrepancy between the two. And you can see this is the continuous wave recording across the aortic valve. However, when we move the continuous wave recording across the mitral valve, you can see we pick up a signal of significant mitral regurgitation. And indeed, when we look at these color flow recordings, you can see that there is significant mitral regurgitation, which is effectively offloading the left ventricle and reducing the forward stroke volume across the aortic valve leaflets, causing a different form of low flow, low gradient aortic stenosis. Now indeed this patient did have significant aortic stenosis, and it becomes a different discussion about whether she would have benefited from TAVI given the severe degenerative mitral valve disease, but that's for a separate discussion. Let's take a typical case that we will often come across. An elderly lady who has dyspnea on minimal exertion, and previously she'd been very active. She's got a loud murmur, she's previously had bypass surgery, but all grafts are patent. And in addition, she's had a left mastectomy and radiotherapy. She has some lung and renal disease, no hypertension, and she has a Euroscore of 19, but was considered high surgical risk. Now, the echocardiogram supplied to us by her referring hospital said that she had an aortic stenosis with a peak gradient of 43, a mean of 23, and a valve area of 0.9. So as you can see, a discrepancy again between aortic stenosis severity based upon the mean gradient and the valve area, the latter of which would suggest critical aortic stenosis. Now, when we look at her 2D echo images, we can see that the problem here is not poor LV function. In fact, left ventricular systolic function in these two images looks relatively normal. However, this is a common situation because in this particular lady with left ventricular hypertrophy, we can see that the left ventricular cavity is actually very, very small. And this leads to the well-described phenomenon of paradoxical, low-flow, low-gradient aortic stenosis. If you have a small ventricular volume, then your stroke volume is going to be small. And we look at this diagram from this excellent paper by Peeberow and colleagues. You can see it illustrates very nicely the difference in the situation between normal flow aortic stenosis and paradoxical low flow aortic stenosis. Both these hypothetical patients would have the same ejection fraction of 60%. However, in the normal situation, the end diastolic volume is 115 mils, but in the patient with the small ventricle, it's only 85 mils, which leads to a stroke volume of 50 mils as opposed to the more normal stroke volume of 70 mils. The valve area in both cases is the same at 0.7 centimeters squared. However, there's an important difference in the mean pressure gradient of 45 in the normal situation as opposed to 25 in the paradoxical low flow, low gradient aortic stenosis, which is indeed what our patient had, and she had significant AS. So we decided to proceed with a stress echocardiogram to prove this, and you can see that the baseline values that we obtained were very similar to those from the referring hospital. A valve area of about 0.9, a maximum pressure gradient of 43, and a mean of 25. Following 20 micrograms per kilogram per minute of dobutamine, you can see that the valve area did not change significantly, remained about 1, whereas the maximum pressure gradient increased to 76 and the mean to 38. So with that information, a more fixed valve area, an increasing gradient, we were relatively confident that we were dealing with paradoxical low flow, low gradient aortic stenosis. So this patient was in fact referred for transfemoral TAVI. And we can see here on these 3D TE images the transverse views of her stenotic aortic valve prior to TAVI, and here with a nicely working sapien valve implanted across the native valve. So let's summarize some of the things that we've been talking about and the role of echo prior to TAVI. As I've already mentioned, it has a critical role in patient selection. First of all, in establishing the severity of aortic stenosis, looking at areas and gradients, particularly mean gradient, with a very low threshold for using stress echocardiography if we have any doubt. Then we can look at the distribution of calcification, the mobility of the leaflets, and any aortic regurgitation. In particular, one of the things that we're interested in is the spatial relationship of calcium on the valve leaflets to the coronary ostia. And we can see in this patient with probably a bicuspid aortic valve that the left main coronary artery is quite close to the calcification. Now indeed, congenital or bicuspid aortic valves are a classical contraindication to TAVI. But I think more of an issue is whether there is very eccentric calcification, because I suspect that we end up doing TAVIs on patients with bicuspid aortic valves without even realizing it, because the valve anatomy is so distorted. In addition, we want to exclude anything that might cause an embolic event, So vegetations, healed vegetations for example, or other mobile structures that might embolize on the valve or on the aorta are things that we should be concerned about. In addition, we need to look at the left ventricle to see what baseline left ventricular function is like and whether there's any left ventricular thrombus which might embolize. An assessment of the mitral valve is important for several reasons. First of all, if there's significant coexisting mitral valve disease, then we need to think about whether this will improve following the TAVI or whether the patient will be still limited by ongoing mitral valve disease. In addition, we want to know what any baseline mitral regurgitation is like in case it should get worse during the TAVI, and we'll be discussing that later in the complications section of this DVD. And finally, I think an assessment of the thoracic aorta is very helpful, because if there is extensive atheroma burden in the thoracic aorta, then this may be an indication or contraindication to a transfemoral approach. And finally, we'll use echocardiography to assist us with valve sizing. Now, this will be discussed in more detail later on this DVD, in particular the relative benefits of using echo in comparison with CT. But from an echo point of view, we have a number of different techniques we can use. And we can start off using transthoracic echo, but as we'll discuss later on, transesophageal echo is always going to be superior. You could use 2D transesophageal echo, but the annulus is a three-dimensional structure, and therefore I believe that it's important to image it in 3D, and if you're going to do that with echocardiography, then it should be 3D TE. So let's spend a few minutes now talking about annulus measurements, and in a separate section of the DVD you'll find a description of how to do this in detail using 3D datasets. Now, starting with transthoracic echo, it's important of course that you optimize your spatial and your temporal resolution. So make sure that you have the system turned into a high frequency mode, or resolution mode as it's called on some systems, and you zoom in on the aortic valve to again optimize your spatial and temporal resolution. And what we want to do is measure from the leaflet insertion points of the right coronary and the non-coronary leaflets. Now, sometimes with a very calcified aortic valve, it can be challenging to determine exactly where those leaflets are inserting into the annulus. So I like to play the loop in real time to assist me, and then reacquire and measure the images several times. And very roughly speaking, if we have an annulus measurement which is in the range of 18 to 21 millimeters, then based upon the current availability of valves from Edwards, then we'd be thinking about a 23 millimeter valve. If it's from 22 to 25 millimeters, then a 26 millimeter valve. And if it's from 26 to 29 millimeters, then we may be considering a 29 millimeter valve. But there are other important issues, as we'll discuss. One of them is that the annulus may not be circular. In fact, frequently it's not circular. So the diameter that we measure in one plane may not be the same as it is in the other plane. And that's another reason why we should be making annular assessments with a 3D technique, be it 3D TE or multi-slice CT. The other important consideration, which is very well evaluated by echocardiography, is that we have to remember that the bulk of calcium on the leaflets here has to fit into the sinuses when it's displaced by the implanted valve. So the valve is going to push the leaflets back, and we need to make sure that there's enough room for those leaflets, and in addition that they'll provide enough support for the valve as well. So let's go back to actually making some annulus measurements. And as I said, you can get a rough idea with transthoracic echocardiography, and it's a good starting point, but I don't believe that this should ever be the measurement that you will make that will finally decide which valve you're going to implant. But as I've already said, we're going to measure from the insertion points of the right coronary and the left coronary leaflet, and I think it's helpful to play the images in real time if you have any difficulty in deciding where to make the measurements. And then I play it in real time, and I'll freeze the image in systole, which is where I prefer to make the measurements, and then measure from the leaflet insertion points, and in this particular case we've got an annulus measurement of 23 millimeters. Now, we've known for some time, and this is the paper from John Webb's group in Vancouver, which discusses the role of echocardiography in TAVI, and they pointed out that measurements that we will get of the annulus from transesophageal echo always come up a couple of millimeters larger than those obtained from transthoracic echo. And that's one of the reasons why a TEE technique is the one that we should use for making our annulus measurements. And the principles that we apply during TEE are very similar to those that I've just discussed for transthoracic echo. We want to measure from the insertion points of the non-coronary, which at this time is going to be the uppermost leaflet because this is a TEE image, to the right coronary leaflet. And you can see it quite clearly on this particular measurement, and we've got an annulus measurement of 24 millimeters. However, sometimes this can be technically very challenging from a TEE point of view because often we will get calcification from the valve leaflets causing an acoustic shadow which obscures the insertion point of the right coronary leaflet and makes it very difficult to make the measurement. So here's an example of a patient with a heavily calcified aortic valve, and you can see a large acoustic shadow which would make imaging quite challenging. And whilst this might be satisfactory for a conventional TEE study, it's not good enough when you want to make annulus measurements. And for those of you who do TEE studies, there are a number of different maneuvers that you need to do. The most important thing is to make sure that this acoustic shadow does not lie over the right coronary leaflet. And here you can see that what I've done is withdrawn the probe and changed the flexion on it, so now the acoustic shadow falls above the valve and I could clearly make the annulus measurement. Now this is exactly the same patient on the right hand side, and all I've done now is to advance it and again change the flexion in the other direction so that now the acoustic shadow falls beneath the aortic valve. In both these cases I could easily make the annulus measurements, whereas you saw before on the previous slide that the right coronary leaflet was obscured and annulus measurements would not be possible. And this applies to both 2D TEE and 3D TEE. It's very important to make sure that you've tried everything you can to get that acoustic shadow out of the way. Here's another example where the probe has been advanced so we can see that the shadow falls above the aortic valve and we can clearly see the insertion point of the right coronary leaflet. Now, as I've already mentioned, the annulus is a three-dimensional structure and its dimension may not be maximum in the AP plane. So you could check this with a short axis view, although sometimes it's very, very difficult to get a short axis view across the aortic valve that's going to be geometrically orientated correctly. So 3D echo is probably preferable in this context. There are other important anatomical considerations, some of which we will discuss later. But here's a patient who's got a sigmoid septum or a septal bulge. And this can cause a number of technical issues during the valvoplasty, one of which being that as the balloon inflates in the LV outflow tract, there may be a tendency for it to move and for the valve to be displaced. In this particular patient, there was an issue because of this sigmoid septum, but in addition you can see that the valve leaflets are not heavily calcified and the sinuses are quite large. Now, when we're going to do annulus measurements with 3D TEE, you can see that what we do is take a 3D data set of the LV outflow tract and the aortic valve, and I like to use a 3D zoom data set for this purpose, and then we can take it into software which does a multi-plane reconstruction. So essentially what it does from that 3D data set is it allows you to create a number of 2D slices, if you like, which can be orientated in any plane you like. And that's the key thing. We can orientate them so that they are geometrically correctly positioned across the annulus. So these are obviously moving clips here, but you can see that we've got two planes here that we could easily measure the annulus across. And in addition, we can see the origin of the left main coronary artery there, so we could make the very important measurement from the left main ostium to the aortic annulus, and we can appreciate that distance. And the reason that's important is we need to make sure that there is enough room for the valve to be accommodated within the aortic root without any obstruction of the coronary arteries. And so sometimes it's important to know exactly what height the valve is, and as you can see from this schematic here, this information is available from the manufacturer, and in borderline cases where you're worried about coronary obstruction, it's important to know how high that valve will sit when it's deployed in the aortic root and whether it will reach the coronary arteries. Now, as I've already mentioned, to do annulus measurements, we will take a 3D zoom data set into software which allows us to do multiplane reconstruction. Software of this type is now available from several vendors, and 3D TE is available from several vendors, and the principles are exactly the same as I'm going to show you here. So we get ourselves a number of views which are orientated geometrically across the aortic valve, and how to do this will be discussed a little bit later on. And then we can make multiple measurements in multiple planes. And I like to look at the maximum and the minimum measurements and take an average between the two for use in my annulus measurements. Now, a slight caveat here is that if the annulus is very oval in shape, very elliptical, then it's going to be very difficult to achieve a good seal, and you may end up with paravalvular regurgitation, and that needs to be taken into account in your overall assessment of patients for TAVI. Now, what we've known for some time, and these are data that we've previously presented, is that when you make aortic annulus measurements using 3D TE, you will come up with measurements which are larger than those that are coming from 2D, which is perhaps not surprising because when we make these measurements here, we're searching in multiple positions around the annulus, so it's not surprising that we'll pick up a larger dimension. But interestingly, the inter-observer agreement for measurements made with 3D TE are better than they are from 2D as well. Now you may say, well, does this actually matter? Well, these are data that we've also presented based upon the original Edwards partner trial where annulus sizing was done with 2D transthoracic echo. But we had 3D data sets in every patient, and when we went back retrospectively and looked at those patients where the 3D echo suggests that we should have actually used a bigger valve size, you can see that these are the patients who ended up with more paravalvular aortic regurgitation. Now, we've done many hundreds of valve implants, valve sizing exclusively with 3D TE now. And interestingly enough, we've just retrospectively gone back now and looked at the 2D and asked ourselves the question, if we just relied on 2D, would we have made the same decision? And the answer is, no, we wouldn't. In approximately 22% of patients, we actually would have chosen a different valve size, usually a smaller one than the valve we actually ended up implanting. And of course, this can be very, very important because valve size has a direct influence over the presence of paravalvular aortic regurgitation, which we know for other reasons is important. And that's really highlighted in this publication, which you can see here, where the authors absolutely emphasize the fact that the presence of significant aortic regurgitation is related to prosthesis annulus discongruence, and therefore to minimize paravalvular AR, appropriate annular measurements and prosthesis sizing are absolutely critical. And that's why we've given it such emphasis in this DVD. Now you may say, well, if we have any doubt, perhaps we should err on the side of caution and go for a larger valve to minimize paravalvular aortic regurgitation. Well, this is a patient very early in our experience. He was a man with a 22 millimeter annulus, a 29 millimeter sinus, but the important thing is he had, as you can see, extensive calcification in the aortic valve and in the aortic root that you can see here. But because he was a large man, we decided to implant a 26 millimeter valve, and you can see this is his transthoracic echocardiogram following implant. And he's ended up with a fistula from the aortic root through to the right ventricular outflow tract. Now, fortunately for this patient, this echocardiogram that you're looking at here was actually taken at his 1-year follow-up from the TAVI, and he's completely asymptomatic, and this shunt is very, very small. So he and we were very, very lucky. But of course, that may not always be the case, and this could have easily led to aortic rupture, which, as you will know, can have catastrophic results. So it's just as important not to oversize a valve as it is to undersize it. Here's another example where perhaps we should have made a different decision, but again, it came from our very early experience, and of course, that's how we learn. So this is this patient with a sigmoid septum, very mildly calcified valve, and very, very large sinuses. And as I've said, the sigmoid septum can cause difficulties with stabilizing the valve during implantation because it can cause the balloon to move. And in addition, because the sinuses are large and because the leaflets are not that heavily calcified, then we might consider that there will be limited support for the valve, and in borderline cases should consider putting in a larger valve than we would have done otherwise. This patient had a 23mm valve and possibly should have had a 26, because as you can see here, this is a 3D TE. During the valve implantation, rapid pacing is occurring, and as you can see during balloon inflation, the valve is displaced up a few millimeters into the aortic root. Today we would have made slightly different decisions. In this particular case, we would have put a 26 valve in this lady, and also we would have done a slow inflation. So had the balloon and valve moved, as you could see, we could actually readjust it during the inflation. As it turned out, we were lucky in this particular patient as well, because although the valve was implanted a little bit too high, it actually worked perfectly and the patient is still doing well. Here's another patient based upon transthoracic echocardiogram and an initial TE assessment we thought would be satisfactory for TOE, for TAVI, because the AP dimension across here was 24mm. But as you can see, this appears to be very, very eccentric aortic annulus. And in fact, on this 2D echo here, it measured medially laterally 34mm, which is clearly too large. But the advantage of having a 3D data set, of course, is we can make sure that this is not an artifact caused by an incorrect alignment of the transverse plane. And here is the full volume data set from this particular patient. We're looking from the apex up towards the LV outflow tract. Now, of course, what we want to do is to look down on the aortic valve. So I'm rotating the data set round, and now we can see indeed that there is a very, very oval aortic annulus and aortic root there, confirming what we'd seen on the 2D imaging. And in fact, what we could also do is do a multiplane reconstruction, which you can see here. And again, this confirms this very abnormal and eccentric aortic annulus, and the patient was turned down for TAVI on that basis. So what we want to do is check the valve and root morphology in multiple views. Check whether the valve is bicuspid or not, because if there is very eccentric calcification as a result of a bicuspid valve, then that can be a contraindication. I also want to look at the bulk of calcium on the valve leaflets and the size of the sinuses, and think about how that's going to fit into the sinuses. Is there going to be room, and is it going to provide enough support for the valve in addition to the support provided by the annulus itself? Are there any mobile masses on the valve that might actually embolize? And are the coronary ostia in danger? Here's a patient you can see who's got very eccentric valve calcification, and this is the left main coronary artery, and you can see there's a large mass of calcification right by that left main coronary artery, which would be in grave danger of obstructing it. And on the basis of this, we decided not to proceed with TAVI in this particular patient. Here we can see a patient who has got a thin fibrinous strand on the aortic valve here, which we gave serious consideration as to whether this might be an embolic risk during a TAVI procedure. In fact, these very thin filamentous strands are not that uncommon, and we believe that they don't embolize. At least we haven't had any serious consequences in our series of patients. However, if it was a larger mass, for example a hill vegetation, then that would be something we'd be much more concerned about and may well turn the patient down for the procedure. Now, as I've already mentioned, the presence of marked subaortic septal hypertrophy, a sigmoid septum, can make TAVI positioning difficult. And one of the things that we need to think about is often we will end up with a valve being implanted slightly higher because there isn't so much room in the LV outflow tract. And you can see here that the position of the right coronary leaflet is very, very close to the septal bulge. And in this situation where the valve is going to be implanted slightly higher, it's one of those situations where we really need to know, is there enough room between the coronary ostia and the annulus for the valve? Now, assessing the position of the left main coronary artery is really a technique that you can only do from an echo point of view with 3D TE. And here's an example of a patient. We can see this calcified stenotic aortic valve. Here is the septal bulge. Now the left main coronary artery is coming off towards us. So what we're going to do is rotate the data set round so we can appreciate that aspect of it. As we rotate round, we're looking up towards the LV outflow tract and the aortic valve from the apex. And I want to point out that the LV outflow tract is very elliptical in shape, and that's common in these patients with a sigmoid septum. And this is a little bit of an aside, but remember that the continuity equation assumes that the LV outflow tract is circular. And when it's elliptical, you make considerable errors in the estimation of aortic valve area. So if you end up with an aortic valve area that appears too small, sometimes it will be because we've incorrectly estimated the LV outflow tract area in a patient with a sigmoid septum. Now I've rotated this data set round. Here's the sigmoid septum. Here is the calcified aortic valve, and there's the left main coronary artery. And as I've already shown you, we can actually measure that distance if we want to, using multiplane reconstruction. Now for assessment of the right coronary artery, we don't normally need 3D TE. Here you can see the right coronary artery ostium in the right coronary sinus on a 2D image. It's another patient with a sigmoid septum where we'd be concerned about a high implant position for the valve, and in particular what I would like to know is whether that right coronary leaflet is likely to obstruct that right coronary artery, or indeed whether the valve implant will be. And you can see that I'm making measurements here of the distance between the sigmoid septum and that right main coronary artery, which is 13 millimeters, in order to assess whether there's enough room for the sapient valve. Here is another patient where we were very concerned about the proximity of this right coronary ostium to the aortic annulus. And when we actually measure it, you can see here that the measurement came up with just under 5 millimeters. And because of our concern that this right coronary artery might obstruct the right coronary artery, this right coronary leaflet might obstruct the right coronary artery, we decided to monitor this during balloon valvuloplasty. And so this is a very useful technique using X-plane imaging, and you'll see more of this used later on. And what we're doing now is monitoring this right coronary leaflet as the balloon inflates, and there you can see the right coronary leaflet being positioned right across the ostium of that right coronary artery. Now, following this balloon valvuloplasty, the patient crashed immediately and had virtually no blood pressure. But because we were half expecting a problem with the right coronary artery, I advanced the transducer into the stomach and did transgastric views of the right ventricle. And you can see that the right ventricle, which was functioning normally prior to the procedure, now has severe impairment. However, a contrast injection into the aortic root demonstrated the right coronary artery was now patent and the leaflet had moved away from it. And so we decided to wait for a few minutes. And as you can see, as we waited, right ventricular function didn't initially improve. And then by about 5 minutes later on, it had normalized. However, because of the potential for obstruction of that right coronary artery, we decided not to proceed with the Tavi in this particular case. Now, the other and important final point that I want to make is that if we are doing a transapical case, then it can be very, very helpful to use transthoracic echocardiography to help locate the apex. And you'll see examples of this in one of the live cases that's contained on this DVD. It's important to use two orthogonal views so we can see exactly where the apex is, and it's also important to do this with the surgeon by your side so you can agree exactly on the intercostal space and the position as to where he's going to do the thoracotomy. Remember that the skin may move during the preparation and disinfection process of the skin, and therefore that needs to be taken into account when you mark up the chest wall. So in conclusion for this particular section, let me summarize some of the points that I've made. Prior to Tavi, we really want to document left ventricular size and function, and document any pre-existent wall motion abnormality. Because if ischemia should occur during the procedure, then that will often manifest itself with a wall motion abnormality, and therefore clearly it's important that you understand what it was like at baseline. In addition, you want to assess for any presence of thrombus within the left ventricular cavity or indeed within the atrium, because this is a relative contraindication to the procedure, particularly if it's in the left ventricle. Again, assess mitral valve function. You want to know what the baseline mitral regurgitation is in case it should get worse during the procedure. You need to be able to detect that because, as we'll discuss later on, there are several potential mechanisms. You also need to evaluate the thoracic aorta, and get some estimate of what the likelihood of embolization of atheroma or thrombus within that thoracic aorta is, because that may well influence your choice of approach for performing the Tavi. As I've just shown you, one of the useful techniques that you can do during transapical approach is to locate the anatomical apex during prior to performing a TA Tavi and using transthoracic echocardiography. So in conclusion, as I've explained, there are a number of different facets of the use of echocardiography for patient selection for Tavi. It really is the gold standard and the key technique in terms of doing this, but of course is used in conjunction with other imaging techniques such as CT, which can also provide very useful information on the aortic annulus and also the aortic root, the ascending aorta, and in particular the descending aorta and femoral vessels, which will have an important impact upon patient selection and also for selection of route for actually implanting the Tavi valve. The use of TE during Tavi does have some disadvantages in that it usually requires a patient to have a general anaesthetic, and that really can be the subject of a separate discussion. However, there are a number of potential advantages, not least of which are the immediate detection of complications that can occur, and that's a subject of a separate section on this DVD. In this particular section, I want to highlight some of the additional information that TE can provide you actually during the valve implant itself and during the valvuloplasty. During the balloon valvuloplasty, we can get some estimate of the balloon size relative to the annulus, and some centres believe that this can help them in deciding valve size. But more particularly, I like to use the balloon valvuloplasty with TE to assess the annulus, sinuses and the leaflet calcification, and to see how the leaflets behave when the balloon is inflated. And I'll show you some examples of that. We have already seen an example in another section on this DVD, assessment of the right coronary ostium and obstruction of the right coronary artery during balloon valvuloplasty, which causes to cancel a Tavi case. So that's a good example of how it can influence your management and how echocardiography can be very, very helpful. Then following the balloon valvuloplasty, we want to assess any leaflet mobility and any aortic regurgitation, because sometimes you can get serious AR following the balloon valvuloplasty, and that you need to know about and act upon quickly. During the Tavi deployment, we use TE in combination with fluoroscopy to help us in terms of valve positioning, looking at the valve plane and the left ventricular outflow tract. And I'll highlight some of the particular features that we want to look at later on in this section. And then we'll also use TE to actually monitor during the valve deployment itself. So let's move back to the balloon valvuloplasty. And as I've already mentioned, the technique that or paravalva and any stenosis, which I have yet to see echocardiography, is the technique of choice. And then finally, assessment of left ventricular function, and hopefully seeing some improvement in LV function in patients who have impaired LV function prior to procedure is usually best assessed with echocardiography. So both pre-procedure, peri-procedure, and in follow-up, echocardiography has an important role to play. And through various aspects of this DVD, hopefully we've highlighted how that can be done best and how you can use echo in combination and to complement the other imaging modalities that are available to us. A key role of any imaging modality in patient assessment for Tavi is measurement of the aortic annulus, which is important in terms of deciding which size valve is going to be implanted. Now, the really important thing to remember is that the aortic annulus is a three-dimensional structure, and therefore we need to image it and measure it in 3 dimensions. And this can be done either with multi-slice CT or with 3D TEE. And I don't think it really matters which technique you use. Both are available, and as I'll show you later on, both give very similar degrees of accuracy and compare very favourably. The other important thing to remember, as highlighted in this diagram here, is that the aortic root anatomy is more complex than perhaps the mitral valve anatomy, in that the annulus that we like to measure is actually formed as a virtual ring by joining the basal attachments of the aortic valve leaflets. So it's not absolutely a complete structure, and as you can see on here, it's a virtual ring formed by joining these basal attachments of the aortic valve leaflets. And that can make it a little bit more challenging in terms of assessing it from either technique. Now, I'm going to focus on this part of the presentation on the use of 3D TE. And as I've mentioned elsewhere in this DVD, the technique I like to use is to acquire a 3D zoom data set incorporating the LV outflow tract, the aortic valve and the aortic root, all of which are key components in the assessment of patients for TAVI. And again, I like to use a high frequency mode and X-res imaging. And then for analysing this can be done with offline software on a workstation, as we'll demonstrate later on, or else it can be done on your Eko machine, again using specialised software, although most 3D TE machines now provide the facility to do this almost in real time and just measure the images directly on the screen. The key thing is that you want to do a multiplane reconstruction of the type that you can see here. So essentially what we're doing is taking this 3D data set and generating a number of 2D image planes which we can manipulate. And as you'll see in a minute, we can change the planes here, and what I've done is to orientate the coronal and the sagittal planes so that they are anatomically correct as they are positioned across the valve. And then we can make measurements of the insertion points of the valve leaflets in multiple planes. In addition, we've positioned this particular plane so we can see the left main coronary ostium, which is positioned there, and if we wanted to measure the distance from that left main to the aortic annulus to make sure we have enough height for the valve, then that needs to be done from 3D TE as well. But for annulus measurements, we'll do this in multiple different positions, and as you'll see in the demonstration a little bit later on in this section, we can rotate these planes to give us multiple views, allowing us to make these dimension measurements again in multiple different planes. And here's another example. Now in this particular image, what we've actually done is to measure the distance between the right coronary ostium and the aortic annulus. Now you can do this from 3D TE, but also you can do it very nicely from 2D, and 3D isn't essential for a measurement of the right coronary annulus. Now how does 3D TE and CT compare? Well, in this particular publication from 2011, you can see a comparison that was performed between angiography, 2D transthoracic echo, 2D transesophageal echo, 3D transesophageal echo, and dual slice CT. Now this is the comparison between dual slice CT and transthoracic echo. And as you can see that there's a reasonable comparison in the sagittal view, but they do not compare so well in the coronal view. When we compare dual slice CT with 2D TE, it gets a little bit better, but it's still not perfect in this coronal view, as you can see here. However, when we compare it with 3D TE, you can see that actually the two techniques are virtually indistinguishable. That there is virtually zero offset on this Bland-Altman analysis between dual slice CT and 3D TE. And the author's conclusion from this paper is that the two techniques give exactly the same answers when you're measuring aortic annular measurements, and it doesn't really matter which one you use. The other important measurement, as I've already mentioned, is this distance between the annulus and the left main coronary artery, and this is a comparison between dual slice CT and 3D, and also using angiography. Since we're considering echo here, let's have a look at it, and again you can see that there's zero offset here, so the bottom line is that both measurements give you the same measurement in terms of distance from that left main to the aortic annulus. And that's also highlighted in this more recent publication, which compared CT, MRI and 3D TE in human in vitro and in vivo studies. Now, in the interest of time, I'm not going to go into all the details of how this study was performed, but you can see some representative images on the right-hand side here. And when you compare the intraclass correlation coefficient for 3D echo, multi-slice CT and CMR, you can see that it's very, very good for all methodologies, irrespective of the degree of calcification on the valve leaflets. Now, variability is perhaps a very, very important feature. And again, you can see that when you look at the overall comparison in all valves, again, all the techniques compare very favorably. When we look at more severely calcified valves, you can see that 3D echo and multi-slice CT compare favourably in terms of their variability, with the best variability being achieved by CMR. Where the valve is more heavily calcified, multi-slice CT is slightly better in terms of variability than 3D echocardiography. Now, in terms of bias, again, when we look at overall valves, and this is using human cadavers, you can see these were compared to CMR, and that there's a slight difference in bias overall. But of course, what we're more interested in is in patients with aortic stenosis who are going to have moderately or severely calcified valves. And again, you can see that both techniques, 3D echo and multi-slice CT, share almost identical bias in terms of measuring the valve annuluses. So the bottom line here is that we have two imaging modalities that are widely used. The key to them is that they are 3D imaging modalities, and it doesn't matter which one you use. On this DVD, we're going to focus very much on the application of echocardiography, and I want to demonstrate a few cases now of analysing the annulus and the left main coronary artery using 3D TE. Now let's look at the practical aspects of making annulus measurements using 3D TE. And the technique I like to use is to start off with a 3D zoom data set, such as the type you can see here, incorporating the aortic valve, the left ventricular outflow tract, and also the aortic root. And I think it's important to incorporate all those anatomical features so you can make a complete assessment of the aortic valve morphology. Now this is a normal aortic valve, and I'm going to demonstrate making some of the measurements on this normal case first of all, and then we'll look at how it differs in patients with aortic stenosis. Now if I freeze this image here in diastole, we can look at some of the features here. And we're looking down on the aortic valve leaflets from the aortic root. You can see the raphe of the leaflets here. You can see how they're positioned up more towards the aortic root. And as we rotate round here, you can see the virtual annulus that we were talking about before. And you can almost get an appreciation that this does not lie in one complete plane. It is a virtual plane that we end up by joining the basal portions of all the valve leaflets. Now to do the measurements, as you've already seen, what we need to do is to import this data set into some multiplane reconstruction software. This can be done offline. It can be done using separate software on your Echo machine, and in many Echo machines, 3D analysis can be done directly on the screen just as soon as you've acquired the data set. So what I've done here is this multiplane reconstruction, and now you can see 3 planes here that have been derived from the 3D data set with this reference image that you can see down the right hand side. Now I prefer to make all my annulus measurements in systole, so the first thing that we're going to do is advance this data set through to a systolic frame, which I can get at by looking at the aortic valve leaflets. So I'm going backwards and forwards, and I've chosen a systolic frame. Then what we want to do is to orientate the green and the blue planes here, and it doesn't matter which ones you choose, to be roughly in sagittal and coronal planes. So I like to start off just by making sure that using these reference lines here, which correspond to the green and the blue planes, that they are roughly in the center of the valve. And then we're going to adjust each of the planes to make sure that anatomically and geometrically we are lined across the annulus. So I will start off first of all by getting the blue plane to run parallel through the aortic root and the valve from the LV outflow tract, the valve leaflets and the aortic root there. So once I have that, then I can reorientate the red plane to be orthogonal to this, and very roughly I'll advance that down towards the annulus that you can see here. And then looking at in this particular plane here, I want to make sure that the green plane that we're looking at here is right in the center, and we can see it's not quite in the center there, so we just move it on this plane here. Now, the next thing I want to point out to you is we can see on this normal subject, without any valve calcification, the insertion of the valve leaflets into the annula, into this virtual annulus here. And notice how I rotate this round, how that moves. Here it is more towards the LV outflow tract, and as I rotate down across the valve, it moves more up towards the aortic root. So notice how that changed, and that really highlights what we're really dealing with is not actually one plane, it's a virtual annulus that moves because of the scalloped nature of the insertion points of the valve leaflets. And we're going to make our measurements at the lowest point, in other words, the point nearest to the aortic valve. And that's what I've chosen here. And now I'm going to reorientate the blue plane to match up with that, so we can see as we rotate it round again, the same feature. And now we have both the sagittal and the coronal planes, and we've frozen them in systole, and we can make some annulus measurements in two different planes. So I'm going to click on the distance mode here, and then we can make a measurement across here from the insertion point, one leaflet to the other, and we have a measurement of 22 millimeters. Then we can do it again from here to there, and we have actually the same measurement. This is a circular annulus, so 22 millimeters in each plane. But of course what we can do is rotate this round in multiple planes and make several different measurements. So we can do another measurement here. And part of our assessment, particularly when we have a feeling that this is an elliptical annulus, is to make multiple measurements. And we've gone up to 25 millimeters in this particular measurement. Now, the other important thing that we can do is obtain an assessment of the distance between the left main coronary artery and the aortic annulus. And the way, again, I like to do this is to move this red plane, almost like a short axis view, up and down, away from the aortic valve, into the coronary sinuses until I can see the origin of the left main. So if I just do that now, as I move it up, I can just see that left main coronary artery coming into view here. Just notice this as I go up and down. Here it is, and now what I'm going to do is adjust the blue plane, so I'm just across it here. So we can see we're right across at that point there, and then we can make a measurement from the origin of the left main to the annulus, which in this particular case is 14 millimeters. So it's always easier, of course, in a normal aortic valve without extensive valve and root calcification. But again, this illustrates the principles of the three key measurements that we need to make. The measurements of the sinuses, which I can just show you here. So we can again do this in multiple planes. So here we have sinuses of about 37 millimeters in this plane, and we can measure them across here as well. And there they're 34 millimeters, and of course we could do that going all the way around, all three sinuses. Then we make measurements of the annulus, and again doing that in multiple planes. And finally the measurement of the distance between the left main coronary artery and the aortic annulus, all of which can be achieved from one 3D data set. Now this is the 3D data set of a patient with severe aortic stenosis who subsequently underwent a Tavi procedure in whom we're going to make the annulus measurements. You can see here, looking at the data set from the LV outflow tract looking up towards the aortic valve. And then, as we previously discussed, we need to validate the data set and make sure we have the complete root and valve contained within it, which you can see I've done here. Notice that there is some extensive calcification and narrowing of the aorta at the level of the sinotubular junction. We can see this ring of calcification, and we can see these very heavily calcified leaflets with poor mobility. But as before, for the annulus measurements, we're going to use the multiplane reconstruction. So let's step into that part of the software and again select our systolic frame, which I've just done now. Now, as it turns out, before we do anything else, we can see the origin of the right coronary artery very nicely on this image. And of course, this is equivalent to the 2D TE long axis image that you would get. So you can make the measurement either from 2D or from 3D. But since we actually have this positioned up here, let's make that 2D measurement from the annulus through to the right coronary artery. You can see there it's only 6 millimeters. In addition, the right coronary sinus is actually very, very small. And so I think there's definitely a potential for this to be obstructed either by the valve or more likely by the implanted valve, or more likely by the right coronary leaflet itself when it's pushed back. And so that would be an important thing to assess during valvoplasty. Now for the annulus measurements, we want to start off orientating our three planes here to make sure that they're geometrically correct. And so, as before, I start off by positioning the green and the blue planes roughly in the middle of the valve that you can see here. then I'll just adjust the blue plane a little bit just so it runs completely parallel from the aortic root through the valve and into the left ventricular outflow tract that you can see here. Adjust the red plane so it runs across the annulus. And then what I'm going to do is maneuver the green plane. And of course I'll make measurements in lots of different planes. So we can make a measurement here, for example, and assess it. From here is the insertion point to the two leaflets there. And we have an annulus measurement of 22 millimeters. And we can go all the way around here and measure it again. This looks like a slightly oval annulus. Let's see what this measurement comes up to be. Well, that's 22 millimeters as well. And then we're going to adjust the blue plane. So let's just move this up and down, find an image where we can see it nice and clearly, and then we can measure across in the other plane. So let's just do this across here, which you can see here, and that's come up to 25 millimeters. So it is a slightly oval-shaped annulus, but not too bad, 22 by 25, so the average being about 23, 24 millimeters, and the sinuses aren't too big. On the other hand, the valve leaflets are not that calcified, so we would be considering the use of a 26 millimeter valve in this particular case. And now let's try and see if we can see the left main coronary artery. And to do that, what I'm going to do is move the red plane up and down so I can try and image the left main coronary artery. And there it is. We can just see it coming in there. So now we'll readjust the blue plane so it falls across it. And now we have the left main coronary artery coming up there. So now we can make a measurement of the distance between the aortic annulus and the left main coronary artery. And you can see it's a much bigger distance than the right coronary artery. It comes out at 16 millimeters, whereas the right coronary artery was only 6 millimeters. And then the final measurement that we want to make is the size of the sinuses, which again I like to do in several different planes. So we measure it there, that's 27 millimeters. And here it's about 30 millimeters. So there's some important considerations here. The annulus measurements alone would suggest that a 26 millimeter valve might be appropriate. But on the other hand, we need to think very carefully about that right coronary artery, which might become occluded. And also, the size of the sinuses is only 27 to perhaps 30 millimeters. And so we need to understand how that calcium leaflet bulk is going to fit inside those sinuses. So I think this is a very good case where imaging the valve during the balloon valvoplasty using X-plane imaging would help us decide whether indeed a 26 millimeter valve is going to fit into this annulus and in particular into this aortic root and the sinuses without causing any complications. Let's look at another example of annulus measurement using 3D echo. Again, we have a 3D zoom data set which I validated. We can see that the whole of the aortic valve and root is captured within the data set. And we'll go into multiplane reconstruction. I've already selected a systolic frame, and the principles are exactly the same as I've shown you before. We'll start off by moving the green and blue planes roughly into the middle of the aortic valve. Now I've chosen this particular data set because the orientation of the valve and the root was slightly different, and it's not completely orthogonal during the acquisition. But the beauty of having this all in 3D is it doesn't matter. You can correct it. And that's exactly what I'm doing now. So you can see here that what we need to do is readjust the blue plane quite significantly so it runs in this plane from the aortic root through the valve leaflets into the LV outflow tract. And then we can readjust the red plane to be orthogonal to that, down on the valve leaflets, and then we have a better idea of what's actually occurring. And now I'm going to move the green plane around so we can make our measurements in multiple different positions. And so we can make one measurement here, and then we can adjust also the blue plane. So now we have nicely adjusted both sagittal and coronal planes. And again, let's just make some distance measurements. So here we have measurement of 21 millimeters. Here a measurement of just over 20 millimeters. And then again, we can do our assessment of the left main coronary artery. So let's move that red plane up the aortic root until we see the left main coronary artery, which you see it coming off here. Now, again, it doesn't matter which of these planes we use, and the green is nearest to this, so I'm just going to move the green plane around until we get the left main coronary artery. It's coming in, you can see there it is, right across where the red plane is intersecting it. So both these planes are intersecting it, and we can make that distance measurement from there to there, and it comes up at 16 millimeters. Now, I've chosen this particular data set because the 3D zoom data set was acquired somewhat obliquely to try and avoid calcification shadow. But again, it illustrates how, providing you have the complete valve and annulus, aortic root and LV outflow tract somewhere within that data set, you can correct for the oblique nature of the acquisition. So again, let's just go into our multiplane reconstruction and start off by selecting the systolic frame. And I like to do this early on in the sequence because the valve can move relative to the acquisition plane during the cardiac cycle. Now you can see that this does look a little bit strange here, and we're off axis. So we're going to reposition everything, move again these right into the middle of the aortic root, and then I'm going to reposition the green plane across the aortic valve like this, and then the blue plane again running through the LV outflow tract like that. Now this time it's the red plane that we have to manipulate to make sure that it's running completely across the LV outflow tract. And you can see now I'm doing extensive readjustment of all these image planes just to make sure that we end up with something that looks as it ought to. So you can see from starting off with a data set where the valve was basically unrecognizable, now by changing the MPR planes, we can get something that is more recognizable for you. Okay, so now let's actually manipulate this and change these planes so we can make the measurements. Now I'm going to adjust this one using the red, just going around here so I'm looking for the lowest point of the leaflet insertion and also the maximum dimensions. And then we can do the same with the blue until we end up tangentially across it, which you can see here. And I'll do this in multiple different planes, adjusting both its position and also its angulation across the valve, which is what I'm doing here, just looking at it and assessing it as we go. And I'll just make a couple of measurements from an illustration point of view. So again, we can make measurements there. That's come up at 23 millimeters and across here. And again, that's come up at 23 millimeters. Now finally, we can also make this assessment again of the measurement of the distance between the left main coronary artery. So I'm going to step this plane up here. And now in this particular case, you can see this is the bifurcation of the LED and the circumflex. This is the left main coronary artery there. And we'll just adjust the blue plane so it comes across it. And we can see that very nicely here. So here's the intersection of the green and the blue plane at that left main coronary artery. And now we can make the distance measurement from that left main up to the aortic annulus, and we end up with a measurement of 16 millimeters. And finally, if we wanted to, we could make some sinus measurements, and I'll just illustrate one of the sinus measurements here for you, but of course we could rotate around and make multiple measurements, and in this particular case we've got a sinus measurement of 29 millimeters. So three key measurements that we require in terms of assessing the suitability and the type of valve, the size of valve that we're going to use for this Tavi case. Let's look at the setup in the cath lab from an echocardiographic point of view. Now this is quite a small cath lab, and therefore we all have to get on well together because we're going to be working physically close together. And the setup we normally have is with our echo machine for the TE positioned over here, and then the TE probe and the ECG electrodes will run through this LED screen here. Now we've had this constructed to allow us to manipulate the probe at the same time as giving us maximum X-ray protection, because there's no doubt that the echocardiographer during these procedures receives probably the highest dose of anyone in the lab. We also have a lead shield down here to protect the lower extremities from radiation as well. So I will be standing here, as you'll see during the cases, manipulating the machine and also driving the probe as well. And then we slave the echo image up here to our bank of monitors, which contains both the fluoroscopy, the hemodynamics, and also the echocardiographic images up here, so the operators can see them all together. Obviously, As you'll see during the cases, there are nurses, anaesthetists, and other staff be working in here. And so the whole layout, how it all fits in with the patient, will become more obvious to you later on. But I just wanted to point out a few specifics from the point of view of echocardiography during these procedures. Our first case is a transfemoral TAVI case, and it's a lady who's 90 years old, who has a Euroscore of 15%, and her transthoracic echo demonstrated an aortic valve area of 0.7 square centimetres, with a peak gradient across the valve of 70 millimetres of mercury and a mean of 40. She also had coexisting mild to moderate mitral stenosis, some septal hypertrophy, but good systolic left ventricular function, despite the presence of some coronary artery disease. So the plan for her is a right transfemoral TAVI, which you're going to be able to see now. Now, for doing the annulus measurements, what I like to do is obtain a 3D zoom image that you can see here, and then we need to validate that that's correct, and we've got the aortic valve in the middle. Once we're happy with that, we can acquire that image and then save it and review it here. So in terms of analyzing it, what we want to do is select a systolic frame. So we're going to step through the data set here until we get a systolic frame, which you can see here. And then I have to geometrically orientate it. So I'm just moving the cursors now into the middle of the valve. And we're orientating ourselves. And as you can see, what I'm doing is a multiplane reconstruction here, just to make sure that I'm looking at the maximum dimensions of the valve in at least 2 planes. Frequently we do more than that, especially if the valve annulus looks elliptical in shape. So as I say, I'm just making some adjustments now, and there's another section on the DVD which explains this in a bit more detail. So now I'm going to make some distance measurements. And as you can see, we've got a measurement of 21 millimeters in that plane, and about the same, about 19 to 20 in the other plane, with sinuses which are about 27, and we're just measuring in the other plane as well, and 27 again. So a 23 valve is the right size for this particular patient. Now, having confirmed that we're going to go with a 23 valve, then obviously there's some other essential things that you need to do before the procedure actually starts. And for example, one of the things I'm going to do now is just check the baseline levels of mitral regurgitation. So this patient has quite a calcified mitral valve annulus, as you can see. Not the world's best 2D echo views, but this is pretty typical. But the mitral regurgitation looks pretty trivial in this view here. And now what I'm going to do is move round to a long axis view, and we'll check it in that plane as well. So again, we have mild mitral regurgitation that we can see here. And then I want to see if I can see the coronary ostia. So we've just seen the left main coronary artery just coming up there, and there isn't any obvious valve leaflet calcification near the coronary artery. And we'll just see if we can see the right coronary artery as well. Now, unfortunately, there's a big acoustic shadow falling across the right coronary artery, which is down here on the image. Probably just about got it in there. And again, I think this will be okay. The sinus is a reasonable size, and it's unlikely that that right coronary leaflet is going to affect it. Then we need to do our transgastric view. So I'm going to go to 0 degrees, and we'll advance the probe into the stomach for the transgastric views. Now, the purpose of this is just to confirm what baseline left ventricular function is like, so that we've established whether there are any regional wall motion abnormalities. And as you can see, it's a fairly small ventricle, but with no wall motion abnormality, but a lot of left ventricular hypertrophy. So now I'm going to go into the longitudinal plane, which we have there. And then we'll withdraw the probe from the stomach in this particular plane here. Looking at left ventricular function as we go out. Big shadow there from this calcified mitral valve annulus. Checking the left atrial appendage as we come out. And now we're back to our mid-esophageal views, you can see here.
So Mark, we've got the pigtail in the aortic root now. We're just going to find a projection that suits us.
Okay. So now they're selecting the valve plane view. And if necessary, we can maneuver the TOE probe to get it out of the way, but that's not usually necessary, and they can find a view that works around the TOE probe, as indeed they've done in this case. So now it's time to cross the valve, and when they cross the valve into the left ventricle, one of the first things that we have to do is make sure that the guide wire is well clear of the mitral valve apparatus, which might be quite challenging in this case because it's a small ventricle. So what we've done is advance the probe now, so I can see more of the left ventricle as the guide wire is being positioned within it, and then I'll pull it back to the optimal position for visualizing the valve annulus during implantation.
There we
Perfect.
go.
RAO, please, Greg.
Yeah. RAO, thank you.
So Mark, we're just moving towards that screen. Sorry, thank you.
So we've got the straight tip soft wire in the
cool.
ventricle.
That should be okay.
We're taking the diagnostic L1 into the ventricle, hopefully avoiding the subvalvular apparatus. Sitting up a little bit upright there.
We'll wait for Mark to tell us it's in the subvalvular apparatus.
It is.
It is in the
subvalvular
subvalvular
apparatus.
Thank you for that, Mark.
Just going to advance the probe a little bit.
So what we're going to do is see what the wire looks like when we position it at the apex.
We should be able to manipulate it out here. It's reasonably flexible.
Yeah, you never quite know.
There's quite a bit of mitral valve annular calcification, which makes it more challenging to see the LV, but we can see enough of it there.
So you can see the angulation on that pigtail here, which is it caught in the cords, Mark?
Yes,
it
is,
looks like it is.
It's going
here.
right across the mitral.
So what I'm going to try and do is I'm going to try and torque it out of the cords. But it may not work, and we may need to cross the valve again, but I don't think we can accept that. A little bit of ectopy there, implying that I'm in the cords still.
Yeah, you are. You're right beneath the mitral valve. So now we can see the wire going straight across the mitral valve subvalvular apparatus and not down towards the apex where we need it. So obviously what we're trying to do is to get the wire to run from the aortic valve here down, right down to the apex, whereas at the moment you can see it's crossing the mitral valve apparatus up there.
How's that wire looking now, Mark? Still the same? Or?
Still the same, I'm afraid, not much better.
Let's have a pigtail on that. I think it's sometimes the route that the wire takes through the valve takes you directly into the mitral subvalvular apparatus, and it's actually quite hard to alter that.
You've actually got a different run through the valve now than you had before. You're more centrally positioned, whereas you were quite anterior before, so it might be slightly easier.
Maybe slightly better. Well, I can put a pigtail on and see if I can torque the pigtail down to the apex. Where's that, Mark?
It's still tangled up in it, unfortunately. It's not near the apex at all. It's about mid-cavity at the moment. You can see, there it is.
How's that, Mark? That looks better fluoroscopically.
Yeah, that's better. You could actually advance a bit more, I think, because you're just...
I think we'll accept that.
We'll accept that. That's good.
You don't mind?
Yeah.
Got it.
Okay.
Okay, so we have it's not right down the apex, but it's more of a mid-cavity position, and it's not too trapped up in the subvalvular apparatus. There's no significant increase in mitral regurgitation. So we're going to accept that. I'm going to pull the probe back now into...
So, Mark, the situation where we've got the wire in the ventricle and we're just about to do the balloon valve repository, we're just going to pause for 30 seconds because the valve isn't quite ready yet.
And we use a 20mm balloon for
We're going to be using a 20, yeah.
So what we're going to do during the balloon valvoplasty is X-plane imaging, so we can look at the way the valve leaflets behave and how they fit into the sinuses as the balloon is inflated. And one of the important things to do with this is to make sure that your transverse plane is at the level of the sinuses, because it's at that point that I want to see how the leaflets are fitting back. So you can see here I've actually chosen a transverse plane which is running across the sinuses, and then we've got it there. So we're actually just above the valve leaflets. So I move it down, you can see there's the valve leaflets. I've just come back up above it a bit. And we'll zoom in on this as well, so we have optimal resolution. And then the other thing to remember is that this is being done under rapid pacing, so your timed acquisition should be done in terms of time rather than beats, because if you set it for a number of beats and we're pacing at 180 or 200 beats per minute, that's going to go very, very quickly. So just from a practical point of view, make sure that you put the acquisition onto a time setting rather than a beat setting.
So we're going to cross this valve now. So Mark, the uninflated balloon is crossing the valve. Just centre us up there, Greg. Okay. Pressure is good, ECG is stable. There's not much wire beyond it, but okay. So we're ready to go now, Raghu. I want 10 volts output, 180 pacing on, please. 180. Bit of hush in the room, thanks. Pressure's coming down, and up we go, John. Nice and gently does it. And pacing off, thank you.
Now the first thing to do is to check on the valve morphology, to check the valve mobility, just see if there's any aortic regurgitation, which is what I'm doing right now. No, it seems fine. No AR. So what we'll do is just review that sequence now. You can see here we're inflating with a 20mm balloon, and that seems fine. There's enough space in the sinuses for those valve leaflets, bearing in mind that we're going to need to allow about another 1 to 2 millimeters either side, because that's the balloon will be inflating to another 3 millimeters in diameter. The valve will be, sorry, when it's deployed.
Okay, Raf, you manage the wire.
Okay, so what we're going to do now is get ourselves ready to look at the position of the valve, and I like to do this in a live 3D mode because that gives me the optimal compromise between spatial and temporal resolution. So I'm just adjusting this now so we have the valve in the middle of the image, and then I want to make sure that the gain is not too high so we can see the valve properly, see the texture of the valve crimped onto the balloon. And also we want to look into it. So if you notice as I rotate this round here, I'm just slightly off the edge here, not going right down to the center of the aortic root, so that we can see, there we go, so we can see right into the valve. And then we'll bring this back here and center it up a little bit. Now I'm just going to rotate that round a little bit more and get it laterally positioned correctly. Okay. So now it's all been positioned across the valve, and they're actually preparing the valve in the descending aorta at the moment. Now from an echo point of view, what we want to try and achieve is that the bottom of the valve is situated at the base of the anterior mitral valve leaflets, and the top of it is going to cover the native valve leaflets you can see there. Now you can see it being advanced across the valve. We can actually see the crimped sapien valve clearly sitting there. There's the top of it, and here's the bottom of it, just here. And so we've got to remember this valve is going to get a bit shorter during deployment. I'm moving the probe all the time. I'm scanning backwards and forwards across the valve plane. This is where we want the bottom of it lined up, and the top of it to cover these native valve leaflets that you can see here. So there's the top of the sapien.
Far off. How's that looking with you, Mark?
It looks actually perfect position. I can see that it's covering the top of the native valve leaflets, and the LV side of it is at the base of the anterior mitral valve leaflet. So from my point of view, that's a good position.
Can I see the pigtail? Just show me the pigtail. It's just caught, it's doubled up.
Disengage, come back and reapproach. follow that.
That's better.
Perfect.
Mag up. Great. Thank you very much. Got that, John?
Got it.
Take a picture
Okay.
there.
Ready?
And that's looking like
That's
a pretty
not
good
bad.
view for us, Mark. It's a tiny bit high, I would say, but I think
We'll move it as we deploy.
we'll move it as we
Yeah,
deploy
it looks pretty good to me, I must say.
Okay. Good. All right. So, Ragu, 180. Pacing on, please. 180. Pacing. Let that pressure come right down, John.
Just move that valve down a little bit.
Just don't do anything.
I'm
Don't
not
do
doing
anything.
anything. No.
Don't inflate. Okay, John.
Slowly. That's
Inflate now.
Slowly.
Up you go. Yeah, it's okay. Up you go, John. Up you go. That is perfect. And balloon down. And pacing off. Thank you. Let me just
There's our 3D acquisition done. Now we're going to immediately go back to 2D imaging just to check that the valve's okay, which we can see it looks like it's in a pretty good position now. Just try a bit of colour flow on there. And this is looking good. We have a trivial amount of transvalvular aortic regurgitation, which is not surprising because there's still a catheter across it. And what we're going to do is just do some X-plane imaging across the valve, just at the level of the LV outflow tract.
The wire's biased across to the right, Mark, so you may be getting some leaflet capture, but we're comfortably under the coronaries.
Yeah, it's looking very good. Like, so far I haven't picked up any paravalve regurgitation at all. We'll just advance this now into the LV outflow tract, just beneath the valve. Remember, we still have a wire across the valve. This looks like a really good result because there's...
Let's not move until we know. So, Mark, we need an evaluation. Any AR? Are you
No,
happy
I
with that
can't see
position?
any AR at all.
Are you happy to take the wire out?
Yes, yeah.
It's caught in a cord, isn't it? Yeah. Lovely.
We can see all three leaflets working nicely in there. We can see the left main coronary artery with flow in it and no valve regurgitation whatsoever, either transvalvular or paravalvular.
Follow us down. Just sit so I can see it's coming very easily. Actually.
Let's go back to a long axis
Leave it there, John.
view to look at this.
This is going to just bleed when this comes out, so just so I don't make a mess. I'll have the introducer back, please.
We have the same level of mitral regurgitation as before. What appears to be a very good result. So we're going to go and try look at the transgastric views now, just to check on LV function, make sure there isn't a pericardial effusion. Just check the MR in this view on the way out. That is unchanged. And again, I cannot pick up any AR whatsoever. So now we advance the probe into the transgastric position. And there's good LV function. No obvious pericardial effusion. We will see if we can get flow across the valve from here, which may be a little bit difficult because it's such a small ventricle, but we're going to give it a try. And now we have Doppler flow across the valve from a transgastric view, which you can see here, with a maximum velocity of about 1.6 meters per second. And no detectable aortic regurgitation on there. So this looks like a really good result. Now, of course, we have to check and make sure there's no pericardial effusion. Just take in the probe out of the stomach into the mid-esophageal view. And we can see that this sapien valve is really in a almost perfect position now. It's covering the native valve leaflets very nicely. You can see the LV side of it is positioned precisely at the base of the anterior mitral valve leaflet, and the top of the sapien valve extends up and covers the native valve leaflets, and there are the valve leaflets very, very nicely collapsing in the center there and moving. And as I said, if we turn color flow on, there is really no discernible aortic regurgitation at all. So we're just going to do a 3D zoom analysis of the mitral valve now. We can see here. Okay. And then we'll just do a 3D zoom data set of the sapien valve for completeness. Which you can see here. And then we'll recheck again the descending aorta on the way out. This has already been done though on the pre-procedure transesophageal echo, and it's important to say that this patient's had a complete transesophageal echo done prior to this procedure as part of her workup for the Tavi. So we just look at the descending aorta. Which does contain some atheroma, as you can see. So it's a fairly atheromatous aorta with a catheter still in it. Okay, Raj, can I take the probe out now? So I always ask our anaesthetist to take out the probe because we want to make sure that we don't disturb the airway on the way out.
So there's an unobstructed way out to the aortic root and valve itself. And what do we mean by the aortic root? Well, the aortic root really extends from the sinutubular junction, which I'm pointing out here. There's a faint ridge just at the top of each of the sinuses. It would include each of the sinuses, the left, the right, and the non-coronary sinus within the aortic root, and then would include the leaflet tissue, really to the basal attachment of the leaflets. And you can see the leaflets extend into the ventricle, and we'll come on to describe that. I'll describe that in a bit more detail in a minute. So the aortic root extends from the sinutubular junction then to the basal attachment of the leaflets. And in order to get a normally functioning aortic valve, all of the components, or the component parts, have to be formed and working correctly to get a normal aortic valve or complex. Let's look a little bit more detail about the support of the valve itself. You can see that there is heterogeneous support of the aortic valve, so it's partly muscular, and in the region beneath the left and the right coronary aortic sinuses, it's supported by septal muscle, but then that gives way to a region of fibrous continuity, between the anterior leaflet of the mitral valve and the aortic valve itself. So the region of fibrous continuity, as you can see, extends mainly beneath the non-coronary leaflet, and usually at the ends of that fibrous continuity there are thickenings which we call the fibrous trigones, and the right fibrous trigone will be closer to the ventricular septum. And then in between those two regions that I've described to you already, we've got a crucial structure which I'm going to transilluminate from the right side of the heart to illustrate to you that it's the thinnest portion of the ventricular septum. It's the membranous septum, and that sits at the base of the triangle of tissue between the right and the non-coronary leaflets. So there you can see the light shining from the right side, sitting at the base. That's an important structure because it marks the position of the conduction axis. So we'd expect the left bundle branch to emerge at the junction of the membranous septum and the mitral valve at this point here. So in the normal situation then, the valve tissue is at some distance from the left bundle branch, but that will change when we get a stenotic aortic valve. The final thing I want to illustrate to you with a normal aortic root is the attachment of the leaflets. And in this heart, we've actually removed the leaflets to show how they are attached and how they begin at the sinutubular junction, you see here, and then run into the ventricle and then back up to the sinutubular junction. And so this gives rise to triangles of tissue, we call them interleaflet triangles, which are between each of the leaflets. And in fact, it's these triangles of tissue which form the distal extent of the left ventricular outflow tract. And they're formed at their top by the arterial wall of the aortic root. And it's important to recognize that because, in fact, if you perforate those triangles, if you're performing a balloon valvoplasty or surgery and you perforate those triangles, you will go outside of the heart. You'll be outside the left ventricle. What I'm showing you here is the interleaflet triangle towards the left side. So this is the left part of the transverse sinus. Here's the left mainstem coronary artery. And if I put a needle through the apex of that triangle from outside the heart, you see we're still beneath the level of the aortic valve. We're still within the left ventricle. So they form the distal extent of the outflow tract. There's 3 of these triangles, and perforating those, as I say, will lead outside of the heart into pericardial space. So this is the overall representation of the aortic valve in the normal heart. We have got rings or annuluses, if you like. The most obvious one, of course, is the ventricular arterial junction between the wall of the aorta and the ventricular mass. Sinutubular junction is often quite easy to recognize. That's at the top of the sinuses. And then the leaflet tissue will extend from the sinutubular junction into the ventricle and cross the ventricular arterial junction. But we can also draw a line around the base of the leaflets, which will be a virtual ring. And in fact, this is the ring that's often measured on echo. It's not a, as I say, it's a virtual ring along the base of the leaflets. And this overall structure then gives rise to these triangles of tissue between the leaflets, and also to a slightly heterogeneous structure of each of the sinuses, because the base of the sinuses, because it extends onto the muscle, will be muscular in this region towards the septum and fibrous in this region towards the mitral valve. So the aortic valve in general then is a relatively complex structure. Important to remember the relationship to the conduction tissue, that it's partly muscular and partly fibrous, and that the hemodynamic junction is semilunar rather than a true annulus. So let's have a look at what happens in the setting of stenosis, to the anatomy in the setting of a stenosis. If you remember, in the normal valve, we had triangles of tissue between each of the leaflets which run the full height of the sinus, so up to the sinotubular junction. And that's because of the attachment of the leaflets. The paradox is that when you get stenosis, the leaflets become attached in a much more annular fashion. In fact, they're attached really along the line of the ventricular arterial junction. And often you'll see the fold or the raphe within the sinus at the point of fusion of the two leaflets. And then beneath that, corresponding to that, we have the reduced height of the interleaflet triangle. Usually, and I put this in just out of interest, the triangle above the mitral valve, so directly above the anterior leaflet of the mitral valve, is better formed. And that may be relevant to the location of paravalvular leaks in certain circumstances. But the point is that the valve is attached in a near ring-like fashion in the setting of stenosis. So I suppose it's more true to call it an annulus in this setting, even though in the normal heart it is not arranged in that way. So let me show you some examples. This one probably is a good candidate for a Tavi valve. So you can see there's fusion here between these two leaflets, and there's also fusion here between the right and the non-coronary leaflet with quite a marked raphe there. The right coronary artery, in fact, is just sitting above the sinus, above the sinotubular junction. So that would be okay. And then here you can see there's quite marked calcification at this junction here. But the interleaflet triangles in all of the regions, in all of the, between all of the leaflets, are reduced in size. And we've got a more annular attachment of the leaflets at the junction. I'll just show you that in another heart with stenosis, but which we've sectioned across. It will show you the relationship now of the valve to the conduction tissue. You see there's fusion between the leaflets, and here between the right and the non-coronary leaflet in particular, there's almost complete fusion between the leaflets and a very small interleaflet triangle just here. And of course the annular attachment of the leaflets now will bring them closer to the membranous septum and therefore closer to the conduction axis in stenosis. And the surgeons are aware of this, and I think it's probably an important thing to be aware of when you're performing a Tavi procedure. So here you can see we've cut across the membranous septum here. So this is right ventricle, tricuspid valve on this side, and the left bundle branch will emerge just at the base of that membranous septum, and you can see that it's much closer here to the valvar tissue in the stenotic valve. Some other examples of stenotic valves. This is quite a trifoliate aortic valve stenosis. There's calcification of the leaflets and also the sinuses, but the calcification really is only of the leading edge of the leaflets, if you like, only of half of the leaflets. The base here is really normal and quite mobile. So I think these leaflets could still fall back into the sinuses, be pushed back by the Tavi quite adequately. And there you can see the calcification extending around the right coronary artery. So this probably is quite a good candidate then for a Tavi procedure, except again that it's got a replacement mitral valve. This one is a ball and cage mitral valve, which is very well endothelialized. It's hard to see the sewing ring in this instance. This heart, I think, might be a bit more of a problem. You'll appreciate, as we view the valve from above, it really is a bicuspid valve with a oval shape or slit-like orifice. Now, there's quite heavy calcification in this example of the leaflets. Notice it's on the arterial side of the leaflets, and it extends really into the base of each of the leaflets, so they're quite rigid and they don't fall back into the sinus as much as they should do. You can see the annular attachment of the valve, very small interleaflet triangle here, and just here. So the question is, should we be putting transcatheter valves in this sort of stenotic valve? Just to illustrate what happens if you try to put a circular valve in this oval-shaped junction, and this is just a simulation, of course, but you can appreciate that you can end up with triangles of space between the circular valve and, the circular transcatheter valve, the cage, and the valve tissue. So these can be the region of paravalvular leaks on either side, and it's the main reason, I suppose, where we don't, that putting them in bicuspid valve is contraindicated. Now this one is probably in between the two. There is fusion, complete fusion between two of the leaflets there, but I think this is probably a functional bicuspid valve, and it may be possible to split this commissure. There is some calcification just here. But the main reason I'm showing this to you is to look at the coronary placement. And if we look at the right coronary artery, first of all, you can see that it's away from the leaflet tissue. The leaflet tissue is quite rigid, and I think if it was pushed back, it would be away from the right coronary artery. But if we look then, turn our attention to the left coronary artery, just here, you can see it's much closer to the valvular tissue, and in fact, there's a calcific nodule there that just wants to fall into the origin of the left coronary artery there. So knowing the coronary origins, I think, is crucial. And in the same heart, in fact, what we've done is put again the cage of the Tavi valve, the Edwards Tavi valve, in to confirm the fact that the right coronary is okay, the leaflet tissue is not obstructing the coronary orifice, but as we move towards the left side, just here, you can see that the cage is now pushing that leaflet and that calcific nodule into, or very close to, the left coronary artery origin. And then the final example, which is a big heart with a very thick wall and a dilated left ventricle, shows a peculiarity of the upper portion of the septum. Again, the valve is thickened and fused, but there you can see fusion between the right and the non-coronary leaflets there, and also between the right and the left coronary leaflets. So it's clearly a stenotic valve, but just turn your attention to this recess here beneath the right coronary leaflet. It's really quite a deep recess, and that's a result of the septum bulging out over and beneath the right coronary leaflet. And the importance of that, which Bushra will emphasize at the end, is that it can displace a Tavi, a transcatheter valve. So you can see here that you need to be aware of the presence of the septal bulge and its relationship to the underside of the cage.